compliance. And also, voclosporin still uses the CYP3A4 system, as does cyclosporin and tacrolimus. And to me, it's hard for me to believe that the pharmacokinetic advantages of voclosporin um, are able to balance the variability in metabolism of these drugs by different CYP3A4 activity between patient X and Y. So I'm not sure how much true drug exposure a patient gets, even when they're taking the drug. Being able to monitor levels, to me, is an advantage over voclosporin. Um, and we don't have it on Parkland formulary, nor have I pushed for it because I don't believe it's all that helpful. Belimumab is also a drug that has, in randomized controlled trials, been proven to be supposedly superior to mycophenolate by increasing the complete response rates. However, one has to be honest about the fact that this randomized controlled trial was flawed in a major way, in that they changed the primary endpoint of the study, the definition, midway through the study, because it appeared that there was not going to be a treatment response by the prior definition. And yet it was published in New England Journal of Medicine. And, I've never prescribed belimumab. It's a mildly potent drug. It has few side effects because of its relative, mild potency. That being said, there is, I'm trying to demonstrate some equipoise in saying there is a randomized controlled trial that suggests it's helpful. There is no comparison between calcineurin inhibitor and belimumab. Clearly, the calcineurin inhibitor addition is a more significant intensification of immunosuppression with more significant differences in efficacy. The NIH protocol cyclophosphamide is another option to consider. Remember, again, in Hispanics and Blacks, this may be inferior to mycophenolate. If you do choose this, the typical dosing would be 750 milligram per meter squared, given in pulse doses over 6 months. And this is something that we often use for the more severe presentations. However, I need to highlight, there is no evidence that supports that practice. I mean, we think of it as being more effective drug or a bigger gun than mycophenolate, but that is not proven by randomized controlled trial data. In fact, a post hoc analysis of the same ALM study showed that even for very severe presentations, which was only a small population of patients in the ALM study, mycophenolate still had, good efficacy compared to cyclophosphamide, and actually had a lower numeric number of deaths than cyclophosphamide. So, just calling into question this presumption that we have that cyclophosphamide is a more potent drug. It is not proven to be so. Urolupus protocol cyclophosphamide is another option. In essence, you get about half the dose that you would with the standard dosing of the NIH protocol. This has to be given every 2 weeks, though. So you give it every 2 weeks for 3 months versus every month for 6 months. And you can see this is not a BSA-based dosing. It's just 500 milligrams Q2 weeks over 3 months. Now, the Urolupus protocol, when compared to standard NIH protocol cyclophosphamide, was proven to be equally efficacious than compared to NIH protocol. However, this was a European study of mostly Caucasian populations, so less statistically less severe outcomes. I've had some failures with Urolupus protocol. I'm not a big fan in the population that we serve of patients with a large number of Blacks and Hispanics. So just that's my editorialization. And if you look at the long-term Urolupus protocol, there was not clear advantage in terms of preservation of fertility or reduced malignancy. So, there was no clear benefit to Urolupus, even though, you supposedly are using less and therefore would have less side effects. And again, it has not been studied in a higher risk population of Hispanics and Blacks. Calcineurin inhibitors can be used without mycophenolate or cyclophosphamide, especially in membranous lupus nephritis. There is a randomized control trial looking at calcineurin inhibitors in membranous lupus nephritis. And then there is also some data, as you know, not quite monotherapy, but calcineurins plus steroids without mycophenolate and cyclophosphamide, even in proliferative lupus nephritis, that is class 3 or 4 lupus nephritis. There are randomized controlled trials. However, this is really in patients from China, but showed to be efficacious. All right, so those are the induction options. For maintenance therapy, you can see the same mycophenolate, thus blurring the boundaries between induction and maintenance. You know, if it's the same drug, you know, it doesn't necessarily need to be protocolized that at 6 months, I'm going to be cutting your 3 gram per day mycophenolate down to 2 grams per day, or that during induction phase, you got to push everyone to 3 grams. You don't necessarily have to do that. If you're responding to 2 grams, call it a win, and you know, don't cause more side effects. You don't have to push to 3 grams, especially if there's GI toxicities or infections that mount. Okay. Azathioprine is certainly a reasonable maintenance agent as well for those that can't tolerate mycophenolate, primarily for GI side effects. However, the ALM study, the same study that I've invoked for the induction therapeutics, also had a maintenance phase. And in the ALM study, it showed that there was reduced relapse rates with mycophenolate, so that mycophenolate appears to be superior to azathioprine in the maintenance of lupus nephritis, but you got to be able to tolerate it, right? So intolerance to mycophenolate is inferior to someone who's tolerating their azathioprine. So let me emphasize it that way. And azathioprine is a good drug. I have patients on azathioprine for maintenance therapy. Okay. You can use maintenance protocol cyclophosphamide through the NIH maintenance phase. This would be quarterly cyclophosphamide over 2 years. However, there is a randomized control trial that shows increased risk of death compared to mycophenolate or azathioprine in patients randomized to quarterly cyclophosphamide. And that was a modern high-risk population out of Miami. So a lot of Hispanics represented in that population. I can't think of, if I did it, it was years ago. I can't think of someone in recent past that I've used maintenance protocol cyclophosphamide. It really would have to be the patient who is really non-compliant, and you need this form of directly observed therapy to be confident that they're actually getting immunosuppression. Calcineurin inhibitors can be used in maintenance treatments, especially for membranous. Again, there's some data in proliferative lupus nephritis, but once again, that's largely limited to East Asian populations. There's one Spanish study that shows it's a beneficial treatment in Spain, a population in Spain, but again, it's not something that has been studied in higher risk patient populations like Blacks in the US. Combination maintenance therapy with calcineurin inhibitor or belimumab could be continued if you used it in induction phase. Okay, so you don't necessarily peel off the voclosporin after 6 months. If you reached a remission, you can continue it into the maintenance phase. Alternative therapies, rituximab is something that we use. However, randomized controlled trial data in both renal and non-renal lupus have been negative studies for comparing rituximab as an add-on to mycophenolate for treating lupus nephritis, and that study was performed here. Actually, the ALM study as well. We were a main contributor to that study. Ramesh Saxena was the co-PI with a rheumatologist here. So rituximab, again, we use it. We use it in patients who might have refractory disease as an add-on, but when compared to when used in all comers, compared to mycophenolate alone, there was no clear benefit of rituximab. So that is, let me just refine that. When you look at just all comers, which include high-risk patients and patients that are, let's say, low risk, who are going to be very responsive, adding rituximab is not clearly beneficial. It's not been studied in any formal way. In the mycophenolate non-responders, whether adding rituximab clearly is beneficial. That's the context in which we're generally doing this. Someone's not responding to standard therapies, we're adding rituximab on. There's no clear, there's no high evidence study that has been done in order to high quality study that has been done in order to determine whether that's a beneficial intervention as well or not. There is now within the last 2 or 3 months a randomized controlled trial of obinutuzumab, another anti-CD20, which has more potent effects and sustained effects on B cell populations, not just circulating B cells, but even B cells in lymphoid tissues. And that was a positive study. Obinutuzumab added to standard therapies did prove to be beneficial. And that's going to, change some of the environment once that achieves drug approval. Okay. IVIG is also something that we've used as a temporizing measure in patients who are infected. And so that would be something to consider. So again, in summary, we don't, treat some of the milder manifestations. We're looking for more severe manifestations like your nephrotic class 5s, your 3s and 4s with significant proteinuria. When we're thinking about some of these induction and maintenance therapies. Guess a word about lupus podocytopathy, since I didn't seem to cover this here, is another way in which lupus can present, where there's essentially a mimic of minimal change disease. So these patients may have little to no changes on light microscopy. On EM, they have diffuse podocyte foot process effacement. And then on IF, they typically will have immune complexes present. EM would also show immune complexes. So obviously, if you didn't have IF or you didn't have EM, immune complexes, you would just call this is a lupus patient who also has minimal change disease, right? So the thing that makes it lupus podocytopathy is the finding of these immune complexes, both on immunofluorescence and electron microscopy. And it often is steroid responsive, so it acts like a minimal change. So if I had a class 2 lupus nephritis, who also is nephrotic, I'd call it class 2 with lupus podocytopathy. Okay, they will have diffuse foot process effacement, and I would treat that patient with just steroids generally. Okay, and we've had a couple of those. All right, moving on to small vessel vasculitis. If there are no questions, yep.